But I was thinking about all the different discussions of the options of care that we'll hear again this afternoon and that you heard yesterday. But I can't know or think of another person that has had more real experience with virtually every one of the options that we talk about. And that is particularly true with the Optria scan, which came into the United States in 1994, was in part pioneered by Larry Coles in his work with Mallinckrodt. I can't think of PRRT without thinking of Dr. Coles with his work, with his collaborative work with Eric Krenning, with the development of the lutetium DOTA octreotide. And I can't think of another person with as much experience, perhaps with the exception of Dr. Warner, with hepatic arterial embolization and chemoembolization, and also his learned experience with the other forms of the embolization. So when he speaks, he's speaking authoritatively and authentically. And for that reason, I'm going to be taking notes as fast as all of you. So with pleasure, I'd like to introduce Dr. Larry Coles.
Thank you for that kind introduction, Tom. How do I turn on this timer? There it is. Thank you. Welcome, everybody. I hope you're enjoying this wonderful conference that CCAN and Dr. Waltring and others have worked so hard to organize. I think it's been a great conference so far, and I hope I can add my little part to it. It's a pleasure to be here. We had our first patient conference in the United States about 10 years ago, and I think we had 75 people attended in Sarasota. The second one was in Tampa, Florida, and there were probably 130, 140. And to hear that there have been over 500 people here is just great, because it's clear the word is getting out about these uncommon tumors. But you heard this yesterday, but I'll reemphasize that if we look at the prevalence of cancers arising in the GI tract, that is, how many people are alive at any one time in a busy GI clinic? How many people are crossing through the door for their follow-ups? Neuroendocrine tumors make up the majority of the patients in a GI clinic. The only tumor that has a higher prevalence is colorectal cancer. The number of people coming in with pancreatic adenocarcinoma, hepatobiliary cancer, are far less than the number coming in with neuroendocrine tumors. That's because people with neuroendocrine tumors can do so well for so long. They keep coming back and back and back. It was interesting yesterday when people were asked to stand up how long they'd had the disease, the number of people who were still standing when they went down to have had the disease for more than 10 years. So it's not uncommon. Well, I have a prodigious task today, and I'm going to break it down into 4 different areas. We're going to talk about somatostatin analog. You've already heard about it, but I want to emphasize one particular study called the PROMET trial. There's a novel combination of 2 chemotherapy drugs. I know you've been hearing time in and time out that chemotherapy doesn't work for these diseases, but I've got a surprise for you. For pancreatic neuroendocrine tumors, it really does work. And then the complicated field of targeting molecular pathways. These are not chemotherapy drugs, but rather we've gotten a little smarter as time has gone on, where we can identify particular pathways inside the tumor cell that are unique to carcinoid or pancreatic neuroendocrine tumors, and we can target them without some of the hideous side effects that we see with more generic cell-killing agents like chemotherapy. So moving right along, octreotide, or sandostatin, is a compound that consists of 8 amino acids is strikingly similar to native somatostatin that you and I have ubiquitously distributed in our body, including the pituitary gland, the thyroid, the stomach, the pancreas, and the intestinal tract. But it's only 8 amino acids as opposed to 14 amino acids for the native compound shown on the bottom. But several of the amino acids, the ones at this end of the hairpin molecule, are conserved, and that's what allows it to bind with high affinity to somatostatin receptor subtype 2. In our first experience with 66 patients, which made up a large part of the Sandoz application to the FDA for approval of this drug, we saw flushing improve in nearly 90% of patients, diarrhea significant improvement in over 75% of patients, and the metabolite of serotonin, 5-HIAA, decreased by half or more in 3/4 of the patients. 10 years later, the long-acting formulation of this compound, called Sandostatin LAR, was approved. But in those 10 years between 1988 and 1998, all of my patients on this drug were giving themselves 3 shots subcutaneously each day. So it was a godsend for them to be able to get 1 shot intramuscularly once each month. Typical dosing is 20 to 60 milligrams every 21 to 28 days, and we have a low threshold for adjusting the dose to maintain control. PROMID study stands for Prospective Randomized Trial of Octreotide in Mid-Gut Carcinoids. It was a study published just a couple of years ago by colleagues of Rudy Arnold in Germany. The study took 85 patients who had small bowel carcinoids metastatic to the liver, biopsy-proven metastatic disease in the liver. The small bowel tumor was resected, and after surgery at 14 different centers in Germany, they were offered participation in a trial and told that they would either get placebo, injections of saline, or injections of Sandostatin LAR 30 milligrams. 85 patients agreed to participate in that randomized clinical trial. It was a double-blind trial, which means the doctor didn't know what the patient was getting, and the patient didn't know. Patients who were getting placebo got saline injections. They got injections once every month, and when the data was finally analyzed, the results are shown here. The patients who were getting the Sandostatin had a time to tumor progression that was 14.3 months, more than twice the time to progression of the patients getting placebo, which was 6 months. So this was proof of a principle that many of us had believed to be true for years before this, because we had seen patients with progressive disease, even though they didn't have serious symptoms of the carcinoid syndrome, put them on Sandostatin and the tumor seemed to slow down its growth. This was a first proof from a randomized, double-blind, placebo-controlled trial. Patients who had a very low tumor burden, that is less than 10% of the liver replaced by tumor, did even better than those with major involvement of the liver, 40, 50, 60% of the liver. The time to progression for those with a low tumor burden was nearly 27 months, as opposed to 7 months for those with a placebo. So the message here is that you don't have to wait until there's a big tumor burden to start Sandostatin. Patients who have a low tumor burden will have benefit from this anti-proliferative effect of Sandostatin. Thank you. This beneficial effect was seen regardless of whether the tumor was making serotonin or not. It was seen whether or not the chromogranin A was elevated. And the most favorable outcome came in those patients who had this low tumor burden, as I just showed you, and those who had had their primary tumor resected. So that's the PROMID trial. I'm going to shift gears here, and we're going to talk about not carcinoid, but pancreatic neuroendocrine tumors, because there's been a major advance in the chemotherapy of this subgroup of neuroendocrine tumors. Don't take what I'm going to say as meaning the drug the drug combination is as effective in carcinoid tumors, because it's not. I credit Matt Kolke with doing some of the initial studies with temozolomide. He studied it in combination with thalidomide as well as in combination with bevacizumab. And we were interested in moving forward on observations that Dr. Fine had made at Columbia University, in which he found in the laboratory that temozolomide was synergistic, worked together with Xeloda, so that the two drugs together worked far better than either drug alone. And he based this on the observation that when they gave 5-FU or Xeloda, which is what we're using as an oral form of 5-FU, in the petri dish in the lab, it depleted in these cancer cells an enzyme that repairs DNA. And when you block that repair, then the cell goes on to die when it divides or tries to grow. So he says he had sustained exposure of these cancer cells in the lab to 5-FU or Xeloda, and then came in with Temodar. And we tried to mimic this in the clinic and gave capecitabine or Xeloda twice a day for 14 days, and then on the last 5 days, days 10 through 14, came in with the other oral chemotherapy agent, temozolomide. All patients were given an anti-nausea drug, and the majority of patients in our trial were also getting Sandostatin LAR. What we observed in 33 patients who were treated was a very significant tumor response. 67% of the patients had a partial radiographic response, meaning a measurable decrease by at least 30% in the sum of the tumor measurements. And 9 of the patients had stable disease. In other words, they didn't progress. Of the 33 patients, only 2 had progressive disease. And this is what's called a waterfall plot. You have to have at least a 20% increase in the tumor size to be progressive. And there are only 2 patients here. You have to have at least a 30% decrease, that's this line, in order to be called a partial response. So all of the patients in the bottom part of this graph on your right had disease responding, and that's the 22 out of 33 patients. These waterfall plots are nice because it gives you a magnitude of the response, not just saying it's response, but this is the amount of decrease, anywhere from 30% up to over 90%. Some examples of patients in our trial, which was published last year. This is a patient with a metastatic insulinoma, pancreatic neuroendocrine tumor making insulin. The patient was having severe hypoglycemia, sweats, tremulousness, and episodic passing out before treatment. And after just 3 cycles of treatment, he was free of symptoms, and treatment was continued for well over a year. This patient remains free of any symptoms even today. Another patient, this one had a tumor producing glucagon. Glucagon causes severe and profound loss of appetite. This patient had lost 30 pounds. You can see the extensive tumor in the liver on the left-hand side of this panel. And after 6 cycles of treatment, 2 weeks on, 2 weeks off, the patient had regained all of the weight, and he remained in remission for 4 years. So the objective response rate was 67% with this, far better than we ever saw with intravenous cytotoxic drugs like 5-FU and streptozotocin. And the adverse events were minimal, unlike some of the other chemotherapy we've used in years gone by. And future randomized studies are needed because at the present time, neither Xeloda or Temodar are approved by the FDA for pancreatic neuroendocrine tumors. They're both approved, so sometimes we can take this data, put it in a letter, and send it to various insurance companies and say, look what we've got here. This patient needs this treatment. Please approve it. But it's not a guarantee. Now, I'm going to move from pancreatic neuroendocrine tumors to talk about specific drugs. You've heard mentioned several times in these 2 days the mTOR pathway. It's an abbreviation for the mammalian target of rapamycin. I won't quiz you on that at the end of the talk, but it's a very important pathway because we've got a specific drug that inhibits the pathway, and that's the drug which used to be codenamed RAD-001. It's now approved as everolimus, or Afinitor. So there were three trials. There's a fourth one going on called Radiant 1, Radiant 2, Radiant 3, and now Radiant 4. Radiant is an acronym, of course, that stands for RAD-001 in advanced neuroendocrine tumors. Oncologists are big on acronyms, just like the military. mTOR is a critical part of the molecular pathways inside the tumor cells and also inside the blood vessel cells. And when we inhibit that, we can bring about reduced gene transcription, reduced cell growth, reduced proliferation, and reduced formation of vascular endothelial growth factor. So all of these work together to bring about control of tumor growth and in some cases tumor cell kill. So there were three trials, Radiant 1, I'm going to talk about them and talk about them first in terms of those that involved pancreatic neuroendocrine tumor patients. This was a trial that allowed patients to enter even though they'd had prior chemotherapy, and patients, if they were on octreotide, could stay on octreotide. So this was not a randomized study. Patients who got RAD-001 in the face of disease progression from their pancreatic neuroendocrine tumors had a median progression-free survival, important term, PFS, progression-free survival, means just what it sounds like it means, that this is the time that patients were alive without evidence of disease progression. So the ones getting everolimus or Afinitor alone had a median PFS of 9 months, and those getting octreotide with the everolimus had a median progression-free survival of nearly 13 months. Again, this was not randomized, so we can't make firm conclusions about this being evidence that octreotide is synergistic with RAD, but it certainly was suggestive. Radiant 3 is the next trial I'm going to talk about because it also involves the pancreatic neuroendocrine tumor patients. The clever in the audience will notice I skipped Radiant 2. That's because I'm coming back to it in a moment, because it involves carcinoid patients. So Radiant 3, pancreatic neuroendocrine tumor patients. This was, this was one of the largest trials ever done. Could you go back to the overview of my slides so I can select the slide? My finger got a little trigger happy here. Go to Radiant 2, please. Okay. What I wanted to show you is that this trial involved more than 400 patients, one of the largest trials ever done, and it involved institutions both in the US and in Europe, and patients were randomized to receive either Afinitor 10 milligrams daily or placebo plus best supportive care. Again, double blind, patient didn't know what they were getting, their doctor didn't know what they were getting, and then they were followed every 3 months with CT or MRI scans. They all had well or moderately differentiated tumors. None of them had poorly differentiated tumors. They had to have had disease progression within the preceding 12 months. They had to have measurable disease. That usually involved either a lymph node or tumors in the liver or something visible on the CT of the chest. They could have had prior chemotherapy, either with cytotoxic drugs or embolization. And as is usually the case with these phase 2 studies, they had to have adequate blood counts, serum chemistries, and performance status, meaning that they had to be up and about, out of bed, off the sofa more than 50% of the time. So the carcinoid patients, 400 of them, the patients who got randomized to everolimus or Afinitor plus octreotide had progression-free survival 16 months. Those getting placebo plus octreotide only 11.3 months. There's something called statistical power, and when Novartis initially approached the FDA before this trial started, they said they were going to achieve a much more statistically significant number. It was not achieved, and so at the last minute in May of 2011, they withdrew the carcinoid component of their new drug application for the FDA. And when we went before the FDA, we just argued for approval of the Afinitor and pancreatic neuroendocrine tumors. So let me talk about that trial, which was called Radiant. Let me talk about the trial that was deemed necessary because the statistical power was not significant. So Novartis decided to study it over again, but this time the patients did not have functional tumors. This trial just opened up at multiple institutions around the country called Radiant 4. Again, it's for carcinoid patients of either lung or GI origin, and they're randomized to get placebo versus Afinitor. So this is a trial if you have a non-functional carcinoid that you might be eligible for if you have disease progression, and it's available at multiple centers around the country. So RAD-001, now known as Afinitor, is active both as a single agent as well as in combination with sandostatin in refractory pancreatic neuroendocrine tumors. The higher rate of stable disease, progression-free survival, and 15-month survival that were observed suggests that perhaps octreotide added to the beneficial effect of the Afinitor. Switching gears again, we're going to talk about the first novel somatostatin analog compound to become available in over 20 years. Octreotide was the first, then along came somatulin, which is approved in Europe, also called lanreotide. But this drug had a code name first, SON230, but it's got a real name now, pasireotide. We did studies in collaboration with other centers around the U.S. and in Europe based on the fact that unlike octreotide, this compound not only binds to somatostatin receptor subtype 2, but also to subtype 1, 3, and 5. So it's a so-called pan-somatostatin analog and binds to several other somatostatin receptors which have to do with cell growth, cell division, and proliferation. In this multi-center trial, we enrolled 45 patients, and they all were refractory to octreotide. In other words, they were having significant diarrhea and flushing in spite of sandostatin 30 milligrams every 21 to 28 days. And 9 of the patients entered in this trial had major improvement in their clinical symptomatology. And this is depicted here, showing a significant decrease in both the flushing and the diarrhea. And this was a tough group of patients because they had been on sandostatin anywhere from 9 months to 9 years. But in spite of that, when they were crossed over to this drug that binds to more somatostatin receptors, 25% of them responded nicely. We are currently enrolling patients in a study that looks at this pasireotide in octreotide naive patients, because I wanted to do this for several years, thinking that if we selected patients who had never been exposed to any somatostatin analog, we might see an even higher response. So that's an ongoing study at my center in Tampa. There's an exciting new category of drugs, and this is a drug that specifically inhibits an enzyme that's involved in the conversion of tryptophan, which we get in our diet, into serotonin, the carcinoid tumor cells are little factories that can convert tryptophan into serotonin. And what happens is that this new drug actually inhibits the first enzymatic step in that conversion of tryptophan into serotonin. You heard yesterday on more than one occasion about the fact that serotonin is broken down into 5-HIAA, 5-hydroxyindoleacetic acid, and that's what we tend to measure either in the plasma, based on the new assay, or in a 24-hour urine collection. Well, this is the first drug to block the synthesis of serotonin for over 20 years. Dr. Warner and I both remember one of the early drugs that blocked serotonin synthesis, but guess what? It blocked serotonin synthesis not only in the peripheral, but in the brain. And serotonin is a critical pathway mediating all sorts of neurologic functions, so it had tremendous central nervous system toxicity. This new drug, the LX1032, does not cross the blood-brain barrier, and it has produced some very favorable results in a phase 2 study that's about to be published. The drug's called tilatrostat, and the majority of patients on this dose-escalating trial, in fact, had favorable symptomatic responses with decrease in flushing and diarrhea. That study has been finished, and Dr. Kolke is going to publish it within the next few weeks. A phase 3 study is about to begin at multiple centers in this country, and it's going to be a study that takes carcinoid patients again who are on a stable dose of octreotide, but in spite of that, still experiencing significant diarrhea, that is more than 4 bowel movements per day. They're going to be randomized initially to receive one of 2 different doses of the LX1032 or a placebo for 12 weeks, but then there'll be a crossover, and if patients are on the placebo during that 12-week period of time, they'll be allowed to cross over and begin therapy with the active drug at the end of 12 weeks. So that's going to be open at multiple centers, and if you have uncontrolled symptoms on Simvastatin 30, you may be a candidate for this exciting approach to managing the symptoms. I'm going to switch gears a little bit again and talk about another pathway, and this is the somatostatin receptor pathway that you've already heard a lot about. Somatostatin receptors on these carcinoid tumor cells were first identified by my colleague and good friend Jean-Claude Roiby. Published this on the cover of JAMA back in 1984, and then he and I collaborated and studied somatostatin receptor expression in more than 100 patients with neuroendocrine tumors. Published that data in 1988. In the meantime, Professor Krenning at Rotterdam took advantage of the fact that these tumors have receptor expression on their surface and decided, well, Dr. Roiby can visualize them in the laboratory with an isotope attached that gave off rays that we could detect on photoemulsion photography. Being a nuclear medicine, why can't I do this same thing and administer it intravenously to patients and attach an isotope that gives off cell-killing beta rays or Auger electrons? So he was the pioneer who first brought peptide receptor radiotherapy to the field of neuroendocrine tumors. And initially, the compound that was used was indium-111. That was the compound that was on the diagnostic Octrea scan, but he knew that it gave off more than gamma rays, it gave off Auger electrons, and these have a very short particle range, but when they're inside the cell, they can damage the DNA. And so, in fact, he did see some objective tumor regression with this first generation indium-111. The second generation compound was yttrium-90, a pure beta emitter, and that's been used quite extensively both in this country and in Europe. Novartis was sponsoring those trials back in the 1990s, but they withdrew their support around 1994. And then Professor Krenning and his colleagues, again at Erasmus University, developed what's called the third generation compound, and that's with lutetium 177. Dr. Krenning and his colleagues have treated more than 1,000 patients. They kindly shared their methodology with Dr. Ibrahim Del Passan, who will speak to you this afternoon about those results with the same compound in Houston. So the basic principle here is that you've got the somatostatin analog, and it's linked to a radioactive material called a radionuclide, and that's called the key, and it binds to a lock, which is the somatostatin receptor on the tumor cell surface. So again, we're exploiting the fact that these carcinoid and pancreatic neuroendocrine tumor cells have somatostatin receptors, the key fitting in the lock, and then it gets taken inside the cell where it can damage the DNA, and when the cell tries to divide, it dies. This has been known as lutate in the literature. It's got a new name now called Lutathera. A couple examples of the experience with this at Erasmus University. On your left, you can see all those dark spots in the panel below. Those are spots of cancer showing up on the Octavia scan. And after a year of therapy, that's 4 cycles at 8-week intervals, you can see that most of those dark spots have resolved, and all of the darker spots on the CT scan shown here are for the most part gone. Overall, in this publication, they reported 310 patients, and 35% of them had stable disease, 20% progressed in spite of the treatment, but the other patients shown on this bottom figure, namely 47% had tumor shrinkage and improvement in quality of life. You'll hear from Dr. Del Passan tomorrow regarding his own experience with this compound. And happily, about 10 days ago, after waiting 6 years, we finally got word from the FDA and the European medical authorities that they've approved our phase 3 trials, taken a hold off of it, so we can start these trials in humans in the U.S. and multiple centers in Europe within the next 6 weeks or so. I'm done. Many of you have been waiting for a long time. I know I sure as hell have been. Who's eligible for this trial? Well, it's going to be limited to carcinoid patients who have progressive disease on sandostatin LAR30. Measurable disease measured on a CT or an MRI has to show progression within the preceding months. They have to be ambulatory, that is up and about, can't be confined to bed more than half of the time. They have to have adequate kidney, cardiac, and bone marrow function, and they'll be randomized to one of 2 arms. FDA demanded this. Wouldn't let us build on the massive experience in Europe. Demanded a randomized clinical trial, and patients are going to be assigned to either sandostatin high dose, 60 milligrams, or the peptide receptor radiotherapy using Lutathera. The trial will start at multiple sites in the U.S. and in Europe within the next few weeks. I've only got about 10 minutes left, and I'm going to touch on some of the other new clinical trials in neuroendocrine cancer. And you'll see that many of these are targeting specific pathways inside the cell. We've gotten substantially more knowledgeable about these pathways in the last 20 years than we were when octreotide first became available. I treated the first patient in the U.S. with octreotide in 1984. Tom Odorizio was also treating patients back then, and it was only 4 short years, namely 1988, before FDA approved it, which was the fastest any drug had ever been approved by the FDA back then. This was before the era of AIDS. It used to take 10, 12, or more years for a drug to be approved. Octreotide, or sandostatin, was so effective, the FDA recognized this as a real need and approved it within just 4 short years. Now we are looking at other pathways besides the somatostatin receptor pathway, but that was one of the first examples of molecular targeted therapy. Another important target is the vascular endothelial growth factor receptor. You've heard that alluded to. The drug that is most well known for this pathway inhibition is Avastin or bevacizumab. But there are several others. One is sunitinib, pazopanib, and sorafenib. The NIB and NAB, the NIB and MAB compounds. So Dr. Yao was really the pioneer with bevacizumab, and he and I have an ongoing trial comparing octreotide plus interferon to octreotide plus bevacizumab in patients who are progressing on octreotide alone. That's accrued well over 100 patients so far, and we hope to complete accrual within the next several months and have an answer for you folks about which one is better. It's also being studied in combination with temozolomide. It's being studied in combination with 2 chemotherapy drugs, capecitabine and oxaliplatin, and it's being studied in combination with Folfox, which is a 3-drug combination widely used for colorectal cancer, but Emily Bergslund in San Francisco is studying it in carcinoid patients in combination with bevacizumab. So these are ongoing clinical trials, and I'm going to give you the name of a website where each and every one of you can go and find out what clinical trials are available and whether any of them are within your area of the country. That'll be coming up on a slide momentarily. So one of the other inhibitors of the vascular endothelial growth factor pathway is sunitinib, and this is the other drug besides Afinitor, which was just approved in May of 2011 by the FDA for treatment of patients with pancreatic neuroendocrine tumors. They did a randomized placebo-controlled trial involving 171 patients, and the patients getting sunitinib had a progression-free survival of 10 months. Those were getting placebo had a progression-free survival half of that, namely 5.5 months. Based on this data, both the FDA in this country and the European medical authorities in Europe approved the drug in 2011. So last May, we had 2 drugs approved for treating pancreatic neuroendocrine tumors. When I'm talking to doctors, I sometimes say, how many of you are driving cars that are more than 30 years old? Oh, there's one. 2. Okay. Actually, I usually get a hand or 2 when I'm talking to doctors also, believe it or not. But these are the first 2 new drugs that we've had approved for pancreatic neuroendocrine tumor in 30 years. Pazopanib is another agent that hasn't been used as extensively as sunitinib, which is also called Sutent, but it's been studied in phase 2 clinical trials where it showed a 17% response rate in pancreatic neuroendocrine tumors, but no responses in carcinoid. So even though carcinoid and pancreatic neuroendocrine tumors look similar under the microscope, they respond quite differently to various treatment modalities. Gefitinib is another inhibitor of a molecular pathway, but this time we're talking about the epidermal growth factor receptor pathway. Not the vascular growth factor, but the epidermal growth factor receptor pathway. And in a phase 2 study of this agent, phase 2 means the first trials in humans with a specific disease. Phase 1, just out of the lab, we want to see what dose is tolerated. And then it moves to phase 2, specific diseases, colon cancer, breast cancer, neuroendocrine cancer, to see if there is significant activity there. So gefitinib was active in pancreatic neuroendocrine tumors and carcinoid tumors. At 6 months, 61% of the carcinoid tumors and 31% of the pancreatic neuroendocrine tumors were progression-free, but disappointingly, only 5 and 9% had any significant tumor shrinkage. But we're not as disappointed about absence of tumor shrinkage as we were in years gone by, because we know that stability of previously progressive disease can be translated into improvement in quality of life and improvement in survival. So we no longer just put the drug in the trash can because it didn't shrink tumors in 20% of cases, but if it has an impact on progression-free survival and quality of life, that can be an important step, because no cancer has been cured with single agents, but we've made major progress in the last 30, 40 years because of the use of combination approaches. IGF is another different pathway. There'll be a quiz on all these pathways at the end. Pass out the quiz. IGF-1 stands for insulin growth factor 1 receptor pathway. And I just show you this cartoon as a springboard for me to move on to talking about it, but the poor medical students I talk to have to learn this stuff. So insulin growth factor receptor 1 is an important signaling pathway in neuroendocrine tumor cells. And there's a compound from Amgen called AMG 479, or now ganitumab, and it demonstrated promising activity in the phase 1 trial, and we're still accruing patients to this study in a phase 2 trial that's ongoing, both at our center and at UCSF. Another compound is a fully humanized monoclonal antibody, and it's being studied in combination with everolimus and octreotide. This is what I wanted to draw your attention to on the bottom part of this panel. Make note of that, because it's your key to a website that will tell you all about clinical trials going on at the website listed by the federal government. It's not limited to carcinoid and pancreatic neuroendocrine tumors, but it's www.clinicaltrials.gov. And investigators around the country, when they open a clinical trial, see to it that that trial is listed on this site, so that you as a patient can go to this site, and if you're in Cheyenne, Wyoming, you can see what the closest place is geographically that happens to have a trial open for your particular disease. And it lists the pancreatic neuroendocrine tumors and the carcinoid tumors separately. www.clinicaltrials.gov. Well, I'd like to conclude by emphasizing that in our multidisciplinary approach to patient care at the Moffitt Cancer Center, the patient is really at the heart. And we have medical oncologists, chest surgeons, gastrointestinal surgeons, endocrine surgeons, gastroenterologists, radiation oncologists, pathologists who specialize in diagnosing these tumors and doing molecular genetic analysis. We work closely with radiation oncologists, and on any given day in my clinic I can turn around and tap my gastroenterologist on the shoulder or lean across and talk to my radiation oncologist. So it's a true multidisciplinary approach, which is what optimizes patient care. As a result of this multidisciplinary approach, we have seen a significant change in the 5-year survival. When I started doing research in this field in 1984, the median survival for patients with carcinoid involving the liver was 12 months. That is, every patient who came through the door lived an average of 12 months. Some lived 3 years, others died within 3 months, but the median survival was 12 months. That was before the era of sandostatin therapy and before the era of all these other improvements such as hepatic artery embolization, interferon, and molecular targeting agents. By 1997, when sandostatin had been around for about 10 years, Professor Modlin did an analysis using SEER data and reported a median survival of a 5-year survival of 36 months. Well, as time went along, we reviewed our data from 4 years ago. Every patient who came through the door at Moffitt over a 10-year period of time, more than 200 of them, and 75% of them were still alive at 5 years. So there's been a dramatic and very favorable change. These are exciting times for researchers and patients in the neuroendocrine cancer field because of the expanding therapeutic armamentarium. Patients are living longer and enjoying an improved quality of life. Very few malignant diseases have been cured with monotherapy, that is, single agents. And we've demonstrated that multi-center trials are feasible, and future trials will need to explore how to combine all these exciting new agents we have available. Thank you. Dr. O'Dorisio, I'd like to point out that I still have 3 seconds left.